हेलो। हाँ हाँ, अभी बीमा लगाइए, बीमा लगाइए।
So you can start now.
Sure. A very warm welcome and good evening to all. Dear doctors, we all know that antimicrobial overuse is a major healthcare issue that contributes to antibiotic resistance. Such an overuse includes unnecessarily long duration of antibiotic therapy in patients with common bacterial infections such as acute bronchitis, COPD, community-acquired pneumonia, urinary tract infections, and cellulitis. International societies have issued best practices for appropriate usage of short course antibiotics. We are fortunate to have with us eminent speaker and authority Professor Prashant Prakash. My humble request to all the attending doctors to please keep your microphone on mute. Once the talk of Professor Prashant is over, we'll be having a discussion and a Q&A round in which you can actively participate and ask your queries. But before we move ahead onto the scientific proceedings, let me share with you the brief corporate overview of Mankind Pharma. Mankind Pharma began its journey in 1995, founded by the first generation of entrepreneur, our honorable chairman, Mr. R.C. Junesh, with a vision of becoming the most admired pharma company in India. Keeping that vision in mind, today we are among the top 5 fastest growing pharma companies, with number one rank in terms of prescription and fourth in terms of top line revenue, which is nearing approximately $1 billion US. Over the years, we have well represented ourselves in almost all the major therapeutic segments with leadership position in many. We are among the top 5 in anti-infectives, gynecology, women and healthcare, gastroenterology, cardiology, and diabetes. Of late, we have been very exclusively working on innovations in formulations and dosage forms for drug delivery. Mankind's R&D center is located in Delhi NCR Manesar. This state-of-art facility has a dedicated team of over 400 scientists involved in complex and innovative research. Some of our clinical research and biopharmaceutical capabilities include new drug discovery and research, advanced pharmacokinetic modeling in biostatics, and formulation and development of clinical research. Mankind's new drug discovery research pipeline includes targets for NASH, arthritis, and diabetes. I'm happy to share that recently our novel GPR119 agonist for diabetes mellitus has shown better glycemic control over sitagliptin, and the molecule has now been entered into phase 1 trial. On the front of COVID-19, Mankind research team is collaborating with Daewon Pharmaceutical for Korea to repurpose injectable niclosamide against COVID-19. After the onset of second wave, Mankind has pledged 100 crores contribution for frontline warriors, including doctors, paramedical staff, chemists, police personnel, and their families. Mankind has distributed 5,000 oxygen cylinders, concentrators with an approximate value of 40 crore for COVID patients, and has also started a 70-bed COVID-19 hospital in Gurugram. Dear doctors, it is with your patronage that Mankind has reached so far. Our endeavor to partner with healthcare providers like you will help us to achieve the objective and mission of improved healthcare in India and abroad. Let me have the privilege and honor to introduce our speaker, Professor Prashant Prakash, HOD and of Pulmonary Medicine, SN Medical College, Agra. Sir has 35 publications to his credit and has contributed 26 chapters in various books and updates. He has been twice awarded with short-term visiting fellowship by ICMR New Delhi, He has the distinction of starting first semi-rigid thoracoscope in Uttar Pradesh in his institution, has also a distinction of starting first super specialty department of pulmonary medicine, UP State Medical Colleges. He is working as a nodal officer swine flu since 2009, nodal officer of COVID-19 since March 2020, and received various awards and accolades. So not standing between your between the scientific agenda and you, I just request Professor Prashant Prakash to take the session forward. Sir, I'm sharing the screen, the presentation which you have shared with us earlier. So I think the presentation is visible, sir.
It's not visible, sir.
Now visible?
Not yet, sir. I think you have to reshare it, sir. It was visible earlier and then it got appeared.
Okay. Now the slides are visible.
Yes, yes.
Uh, support, can I share the control with Dr. Prashant?
Sir, we already gave a full control.
Sir, can you, are we audible to you, Dr. Prashant, sir? Sir, your voice is muted, sir. Sorry, microphone is muted. You have to unmute the microphone, sir.
Yes. I would like you to share the control of the slides with me. Or
Sir,
will you be doing it?
Sir, I will be doing it because at this juncture it's not possible to hand over the controls to you because there are some technical difficulties. So you just tell me to move ahead. I will just move ahead, sir.
Yeah. So our distinguished members who are participating in this webinar, my basic topic is regarding short course antibiotics and emphasis on short course antibiotics. What do we know about antimicrobial overuse and resistance? We all know that inappropriate use of antimicrobials has posed a global health care challenge. Antibiotic prescription is very common in private primary care practice. Many times a broad spectrum antibiotics are prescribed in cases with acute infections due to non-feasibility of bacterial cultures or lack of access to diagnostic tests. Antibiotic growth promoters in livestock is also a contributing factor. And most important in India, self-medication is another major factor contributing to antibiotic resistance. So antibiotic overuse can cause adverse effects such as allergic reactions and Clostridioides difficile infections. Long course of antibiotics also increase the chances of antibiotic-related side effects. So hence clinicians, especially primary care physicians, they play an important part in antimicrobial stewardship. Next slide. Longer antibiotic course. Now, longer antibiotic course has always been viewed that it helps in preventing antibiotic resistance. Such statistics suggest that 1/3 of prescription antibiotic courses are longer than necessary. Longer antibiotic courses not only cause antibiotic associated adverse events, antibiotic resistance, and emergence of resistant pathological states, but also heightens the pressure among commensals to select for antibiotic resistance. The latter can lead to serious infections in the future. Resistant strains of microorganisms render first-line antibiotics ineffective, and this imposes a huge cost when we use second-line drugs. In some cases, lack of access can lead to treatment failure. Next slide. The emphasis on short course antibiotics, shorter antibiotics regimes demonstrate long-term benefits and can prevent development of resistance and reduce risk of side effects. However, despite guidelines favoring shorter duration use, longer course of antibiotics still seems to be the norm. It's frequently being prescribed regardless of the severity of the infection or the resolution of symptoms. There exists a lack of evidence regarding antibiotic efficacy beyond symptom resolution. And literature suggests that efficacy of shorter antibiotic courses in common bacterial infections in both inpatient and outpatient healthcare settings. Next slide. So when we come to the debate of long versus short care antibiotics, short course antibiotics, previous guidelines recommend completion of the antibiotic course despite resolution of symptoms. The emphasis is that even if the symptoms are over, you should continue the course of antibiotics. These guidelines were developed before antibiotic resistance became prevalent or became a now major problem. Longer antibiotic courses were suggested earlier to prevent reinfection and treatment failure. Shorter antibiotic courses were deemed inferior treatments in the yesteryear. They were considered inferior as compared to the norm today. However, periodic updates of guidelines have had negligible impact on physician prescribing patterns. Over time, short course antibiotics have shown comparable efficacy to longer courses. Next slide. The role of antibiotic susceptibility testing. It helps in specifying antimicrobial agents that could be effective against a pathological organism causing a disease or infection. These tests help in prescribing specific antibiotics rather than the emphasis on broad spectrum antibiotics, and thus help in minimizing chances of development of resistance. Next slide. Well, this is the American College of Physicians recommendations for antibiotic use in common. You have acute uncomplicated exacerbation of COPD. This is something which is day in and day out seen in general practice with incriminating organisms such as Haemophilus, Streptococcus pneumoniae, and Moraxella catarrhalis. And the antibiotic use is amoxicillin clavulanic acid, azithromycin, or doxycycline. Duration seems to be, as per now the ACP recommendations, 5 days is more than sufficient. Coming to community-acquired pneumonia. Next slide. Oh no, previous slide, please. Community to community-acquired pneumonia. So where we have the incriminating organisms such as Streptococcus pneumoniae, Haemophilus influenzae, Mycoplasma pneumonia, and rather rarely Staph and Legionella. So here also again you have amoxi, doxy, azithromycin, which are to be prescribed. When you deal with Staph aureus or Legionella, there you have to use a combination with beta-lactam with macrolide. But duration, again, as per ACP norms, is 5 days. Next slide. So again, the ACP recommendations for UTI, uncomplicated cystitis in women, you have nitrofurantoin, you have Septron, you have fosfomycin, you have urinary fluoroquinolones, but the duration is 5 days, 3 days, 5 days, 3 days. Uncomplicated pyelonephritis in men or women is, of course, here you have to go for antibiotic selection via culture and susceptibility. And here the duration is definitely 14 days. Then coming to non-purulent cellulitis, where the culprit organisms are Streptococcus or Staph aureus. So here you have a combination of cephalosporin, or you can use dicloxacin, or you can use clindamycin. But again, when it comes to duration, it is 5 days. So what you have seen by ACP recommendations is that each time the duration, except for uncomplicated pyelonephritis, the duration has never exceeded more than 5 days. 5 days, 7 days. Only uncomplicated pyelonephritis was one infection in which 14 days was the norm. Next slide. So ACP best practice advice, once again, to repeat, for COPD exacerbation, acute and complicated bronchitis, 5 days is more than enough. For community-acquired pneumonia, 5 days is more than enough. In women with uncomplicated bacterial cystitis, short course antibiotics is recommended, right? 5 days more than enough. In men and women with uncomplicated pyelonephritis, here we do have to go on for 14 days. In patients with non-purulent cellulitis, a 5 to 6 day antibiotic course is more than enough. Next slide. Coming to real world evidence, a 2019 article published in the BMJ evaluated the duration of prescriptions of antibiotics in the primary care to assess guideline adherence amongst healthcare providers. The findings revealed that a majority of antibiotic prescriptions occurred in cases with upper respiratory tract infections and acute cough and bronchitis, which accounted for more than 2/3 of the total prescriptions. However, more than 80% of the antibiotic courses prescribed exceeded guideline recommendations. They were long, too long. Overall, more than 50% of antibiotics were prescribed for longer durations than the guideline recommendations for acute cystitis in females. Hence, it was inferred that for the most common infections treated in primary care, a substantial proportion of antibiotic prescriptions have durations exceeding the guideline recommendations. Substantial reductions in antibiotic exposure can be achieved by just simple guideline adherence and adopting short course antibiotic prescriptions into mainstream. Next slide. NICE and Public Health Guidelines, Public Health England have collaborated to recommend antimicrobial prescribing guidelines for common infections. The guidelines encompass recommendations on the choice of antibiotics, their dosage and course. Their general advice suggests the shortest effective course must be chosen. Next slide. Coming to antibiotic stewardship. Antibiotic stewardship. It is optimizing the use of antibiotics, which is important to treat infections effectively, protect patients from harm caused by unnecessary antibiotic use, and combat antibiotic resistance. So antibiotic stewardship programs help clinicians improve clinical outcomes and minimize harm by improving antibiotic prescribing. Hospital antibiotic stewardship programs increase infection cure rates and reduce treatment failures, Clostridium difficult infections, adverse effects, antibiotic resistance, and hospital costs and lengths of stay. New CDC data suggests that more than 50% of the antibiotic prescribing data for selective events is not consistent with recommended prescribing practices. Like, next slide. Hospital prescribers and pharmacists can improve antibiotic prescribing by optimizing antibiotic selection, reassessing antibiotic treatment when results of diagnostic testing are available, and using the shortest effective duration of therapy. Next slide. So, what we want to know and what we want to emphasize is more is always better now does not work for antibiotic. More is always better now does not work for antibiotic. Next slide. What do the Indian guidelines now specify? So, Indian Council of Medical Research illustrates the following treatment guidelines for antimicrobial use. The steps of rational antibiotic use can be divided into practically 7 or 8 steps. Step 1 is most important, making a clinical diagnosis of infection, which will help to predict positive pathogens and tailor the correct antibiotic. So, step 1 is, first of all, is it an infection? How likely is that the patient has an infection? What are the possible non-infectious mimics? And have we taken the appropriate cultures to confirm the final diagnosis before we start treatment? Next slide. Step 2, limit empiric antibiotic therapy to only very seriously ill patients, like those with febrile neutropenia, severe sepsis and septic shock, community-acquired pneumonia, ventilator-associated pneumonia, and necrotizing fasciitis. Step 3 is know your bugs by identifying the clinical syndrome, sources of infection, possible microbial pathogens, and local resistant patterns. Step 4, choose the appropriate antibiotic. Choose the appropriate antibiotic based on the spectrum of the antibiotic, possible resistant patterns, correct dosage, route, and duration. Next slide. Step 5. Very important, de-escalation or modification. Modification of the empirical broad spectrum antibiotics based on culture and antimicrobial susceptibility reports and patient status. Stop antibiotics in situations like the respiratory tract syndromes, which are such as viral pharyngitis, viral rhinosinusitis, viral bronchitis, non-infectious cardiopulmonary syndromes misdiagnosed as pneumonia. Skin and soft tissue infections, subcutaneous abscesses, lower extremity stasis dermatitis, then you have asymptomatic bacteriuria and pyuria, you have microbial colonization, low-grade fever. In all this, you have to stop antibiotics. Next slide. So, reduce what the ICMR guidelines, they also say, reduce the duration of therapy as community-acquired pneumonia, 5 days is sufficient. Skin and soft tissue infections, 5 days is sufficient. Hospital-acquired pneumonia, 8 days is sufficient. UTI can range from cystitis needing only 3 to 5 days. Pyelonephritis needing 5 to 14 days. Catheter-associated diarrhea include 7 days. Staph aureus bacteremia, where there is low risk of complications, 2 weeks. High risk of complications, 4 to 6 weeks. Intra-abdominal infection, 4 to 7 days. And surgical antibiotic prophylaxis, 1 dose. Optimize pharmacokinetic, pharmacodynamic parameters by including loading doses when needed, therapeutic drug monitoring for toxicity and efficacy, and optimization of drug infusion or administration. Next slide. So here we have the standard doses of antimicrobials. We need not go into the details of all of them, right? Ranging from cotrimoxazole to cefoperazone and sulbactam. Next slide. Again, you have the higher end antibiotics and the antimalarials, their respective doses. Next slide. Patient attitudes and patient attitudes, expectations, and behavior with short-term antibiotic course. A pan-European market study of 3,254 patients with mild to moderate RTIs described the following regarding the short-term antibiotic therapy. It is perceived to be significantly more effective than normal antibiotic courses. It better meets patients' expectations of therapy. Improved overall satisfaction is seen with management by the physician, and patients show better compliance with therapy. Next slide. Next slide. Yeah. So now going into the analysis of evidence for short course antimicrobial therapy. Starting with various infections such as acute maxillary sinusitis. So, despite limited data, a descriptive analysis of acute sinusitis trials provides preliminary evidence suggesting that less than 5-day courses of therapy are equally effective as more than 8-dose courses of therapy. 6 trials involving 620 patients found clinical or bacteriological efficacy of various classes of antibiotics, similar for 3 to 5 days course and 8 to 10 days course. Next slide. Same talking about uncomplicated cellulitis, a randomized double-blind placebo-controlled trial assessing 121 subjects with cellulitis after administering 5 or 10 days of levofloxacin at a dose of 500 milligrams per day. So what was found was that there was no significant difference between the outcome of the 2 courses of therapy. Dr. Ashutosh, can we have the next slide, please?
Yes, sir.
So, again, coming to community-acquired pneumonias, where RCTs comparing a short course or long course of antibiotic treatment were done. So, again, there was no significant difference between the outcome of both patients. Next slide. Similarly, randomized controlled trials were done on at least 4 illnesses in children and 4 illnesses in adults. Children being group A streptococcal tonsillopharyngitis, CAP, acute otitis media, UTI, and in adults, acute bacterial sinusitis, uncomplicated cystitis, acute pyelonephritis, and community-acquired pneumonia. And in all these RCTs, the short course antibiotics were as effective as longer courses. Next slide. Prosthetic joint infections. Again, the treatment duration, whether it was 3 months in total knee arthroplasty or 2 months in total hip arthroplasty, they found similar treatment durations when compared to 6 months and 3 months respectively. Next slide. Post-operative abdominal infections in critically ill patients. So when a 8-day versus 15-day antibiotic therapy trial were compared, then benefit shown by short course over the long course were that there was a higher median number of antibiotic-free days, equivalent in terms of 45 days mortality. The similarity in terms of ICU and hospital length of stay, the emergence of MDR bacteria, or reoperation rate, they were all in favor of short course versus the long course. Next slide. Very important entity, spontaneous bacterial peritonitis, a randomized controlled study of 90 patients with SVB compared 5 to 10 days, 5 days to 10 days of single agent cefotaxime given 2 grams TDS. They found no significant difference between the two groups regarding infection-related mortality, hospitalization mortality, bacteriological cure, recurrence of ascitic fluid infection. Next slide. Same is true for
So your voice has gone, Dr. Prashant.
Yeah. It's come. There was an incoming call. Yeah. So a common short-term antimicrobial therapy for the management of both osteomyelitis and septic arthritis, minimum of 15 days, is a practical option for treating acute hematogenous bone and joint infections. Next slide. Same goes for Enterobacteriaceae bloodstream infections. The recommended duration of antibiotic treatment is 7 to 14 days. Comparison between patients receiving short course 10 days versus prolonged course antibiotics see no difference in mortality, CBI, and antibiotic therapy on emergence of multi-drug resistant bacteria. Next slide. Next slide. Gram-negative infections, mechanisms of resistance that make the patient more vulnerable to recurrence of infections. Recent findings suggest that no additional clinical benefits at a certain point rather than might have. They have also patients with severe infections whose control is adequate can be managed with short course antibiotic therapy, 7 days or less. Next slide. Same is true for group A streptococcal tonsilopharyngitis. There was only a small variation that short course cephalosporin treatment was superior for bacterial cure rate than 10 days of penicillin. However, a short course of penicillin therapy was inferior in achieving bacterial cure versus 10 days of penicillin. So here there was a variation. Next slide. So Alexander Fleming, in his Nobel Prize acceptance speech for his penicillin discovery, described a hypothetical situation where a person self-treats a sore throat with antibiotic. So he says that that is the patient buys some penicillin and gives himself not enough to kill the streptococci, but enough to educate them to resist penicillin. He thus advised, if you use penicillin, you use enough. Next slide. Uncomplicated childhood cystitis, again, standard course of 4 to 5 days is more than sufficient. Next slide. Osteomyelitis, short course antibiotics 2 to 3 weeks are safe and effective in children with acute osteomyelitis. Long course 6 weeks should only be used in vertebral osteomyelitis, especially in patients with Staph aureus infections. Next slide. Hospital-acquired pneumonia. Recurrences are greater after short course therapy in VAP due to non-fermenting gram-negative bacilli. Thus, in patients with VAP not due to non-fermenting gram-negative bacilli, a short fixed course of 7 to 8 days is suggested over a prolonged course 10 to 15 days. Next slide. Acute exacerbation of chronic bronchitis in patients with acute exacerbation of chronic bronchitis was found that short course 5-day gatifloxacin therapy has a comparable clinical cure and microbiological eradication rates to those of standard 7 and 10-day therapies. Next slide. Neonatal septicemia. On comparing a short course of antibiotics, 48 to 96 hours, with a standard course of antibiotics for 7 days for probable neonatal, there was no difference in the treatment failure rates. Next slide. So shorter courses of antibiotic therapy have been successfully tried in typhoid fever, 3 days, meningococcal meningitis, single dose to 3 days course, ventilator-associated pneumonias, 8 days, possibly ICU-associated infections, 3 to 5 days, and however, IV catheter-associated infections require full treatment courses to the extent of 14 days. Next slide. The finish the course message is no more needed. Next slide. Thank you.
Thank you very much, Dr. Prashant. I will now request the doctors to raise their questions. You can unmute yourself. Please tell your name and you can go ahead with the questions. Sir, to set the ball rolling, since we have heard a lot about short course antibiotics, but in India, we often see that by the time if a patient is coming to me for an acute bronchitis, and if I don't prescribe antibiotic, they will rather change a doctor because Dr. Google is there. And many times people are going through Google and they have a pre-notion that they should be prescribed antibiotics. So how to deal with that?
Well, as far as short course antibiotics therapy, well, your question is regarding that they will tend to go on Google, or they will tend to go for further go. I think what we can do is that ultimately education of the patient and his relatives are more important regarding the necessity to use short course antibiotics. And you just have to educate the patient that you're not going to gain much by sort of, going for a long-term antibiotic therapy. In fact, you're going to be exposed to a host of adverse effects due to this long-term course.
Very right, sir. So any of the doctors or who have listened to the Dr. Vashni, if you want to ask something, please go ahead. You're audible, Dr. Vashni. Dr. Vashni, anyone else? You're audible, sir.
Yeah. I think no questions seem to be forthcoming, so we can wrap up the
Yes, sir.
session.
Yes, sir. So, sir, on the behalf of my Life Mankind and myself, I thank Professor Prashant for such an enlightening session. Last but not the least, I thank all our doctors who have been attentive during this entire session. Yes, yes, Dr. Akhilesh, you want to ask something? Dr. Akhilesh? Fine, sir. So thank you very much for your presence on this webinar.
For the opportunity. Yeah, right.
So please go ahead, sir.
Thank you so much for the opportunity. And I think we can close the session.
Yes, sir. Yes, sir. Thank you, sir. Thank you very much for your time, sir.